Good morning, everyone. Thanks for joining us for our grand rounds this morning. It is my pleasure to welcome Dr. Kamlesh Patel to present this morning. Dr. Patel is a professor of plastic surgery at Washington University School of Medicine. He completed his medical school training at the University of Arizona, then went on to complete his plastic surgery training at the University of California, Davis, and a fellowship in craniofacial surgery at Boston Children's Hospital. He is currently director of craniofacial surgery at St. Louis Children's Hospital and director of clinical operations for the Division of Plastic Surgery. His research interests include a series of patient, provider, and system-focused explorations of the challenges in multidisciplinary care, including efforts to make multidisciplinary care more efficient, more cost-effective, and more responsive to the needs of patients and caregivers. And with that in mind, I welcome him to share his experience and his thoughts.
Now, a huge thank you for the invitation. I think I realized a couple of days later after the invitation, you told me the specific talk you wanted that I don't have the talk. So I had to produce it, but I'm still excited to be here. But hopefully everyone get an idea that I try to keep it as non-surgical as possible. The idea is just focus on how can we do coordinated care in a more efficient manner. So these are my disclosures, consulting and advisory board. So we talk about multidisciplinary care. It's how do we take a patient, and when we talk about, this is pediatric, how do we take someone that's medically complex, like the picture here at the top, get them through this whole timeline, and then get them to the point where the end product is someone who's, you've met all their physical needs, their social needs, their psychological needs, so that they're integrated in society and super confident, flexing away like that one patient is there. And, how did the idea for coordinated care, or how did it get organized in the first place? And it was back in 1987. It was a conference that was, heavily sponsored by the American Academy of Pediatrics and the Surgeon General kind of working together. And at that conference, they came away with these 7 steps. And as I go through the talk, I'm going to it almost forced me to did we actually meet any of these 7 steps? I think of these are the 7 commandments when it comes to coordinated care for children. And I highlighted just a few words. There is a commitment. There has to be a community-based component. There has to be some training. The delivery of the services has to be done efficiently. Some guidelines, and in particular, controlling the costs. Support. It's crazy. Even back in 1987, they knew that support would be needed from the healthcare system, and research and dissemination of that information has to be key. It's amazing that they thought about all of this in 1987, and I think it's something that still resonates now. A couple of years later in pediatrics, they provided a bit more definition from that original recommendations, like what is family-centered care, what is community-based care, and exactly what is coordinated care between the tertiary care center and the local team that's with that patient. They highlighted a few things in this paper as what's actually key to be successful. You need care coordinators, sometimes multiple. You of course need the big tertiary medical center like this one to actually provide all the care. Some financing of that coordinated care is incredibly important. And that's probably one of the toughest challenges to figure out. And I probably fight that challenge every 2 years. And the important role of the pediatrician in their the local community team. So our Cleft, American Cleft Palate Association, took this and then tried to develop their own parameters. So you can see all the team members that can be part of a Cleft team. And this is probably similar to many other multidisciplinary teams. But what they did identify that at minimum, you need an orthodontist, a speech pathologist, and a surgeon to be recognized as a Cleft team. This is our Cleft team. And, yes, it's kind of similar. Probably the team here, we have a lot more than just those 3 minimum requirements. And it is that number 4, develop that coalition. The nurse coordinator, that's the key position. And we're fortunate to have 2, and you do need them. To be able to build that community relationship and be that liaison between the local team and the tertiary care center. That 7th commandment, the research and dissemination. This is the one where you do need research support. And it goes into QI at the same time as well. But in our case, we have a coordinator and a database manager. We both started at the same time. He's great. Yeah, you could tell the researchers, because they always keep asking questions. Why are we doing this? Why are we doing it this way? And always challenges at the same time. So we think, and this is where the twist happened. Everything looks great here. We're like, everyone looks really happy. We must be a fantastic team. Everyone's great. But here's where the twist happens. It's probably, I want to say about 5-6 years into practice. I have my Excel spreadsheet where I follow the patients, not as fancy as the system that's being used here. But there was a lot of empty spaces. And then I started asking other people, like, how many actually keep following us through this really long process, beginning of team care to the end of team care? We went through a few months where it's like, oh, we don't really want to look, but nobody wants to know, but I think we should find out. So this was the paper that really started it off and helped start the conversation of like, are we actually getting patients to go all the way from beginning to end? And this is still painful to look at, but we might as well show it. But so, you're supposed to follow these patients until about 12 to 18 years of age, depending on what their diagnosis is. But we lose about a quarter of them just under age 4. And then half of them are gone by age 8. We went a little further to try to figure out, okay, let's ask some of these people that stopped coming. Why did they stop coming? The 3 biggest categories are they didn't see a need, cost was a problem, and there was an educational component that we were missing where, the future president of medical staff office just walked in. I just wanted to highlight that Dr. Dustin Rayham is here. Yeah. We were medical classmates. I'm allowed to do that. And then there was an education component as well, where they just didn't feel like there was a need to come in. So I tried to organize like, all right, what did we exactly do? And it's sometimes nice to do a talk because it helps to organize all the different things that we did. And I put it into these 5 different categories. First thing it was like, instead of trying to reinvent the wheel, I'm sure somebody else has figured this out, so we don't have to do as much work. So let's learn from other centers. So we did this survey to try to figure out, how do other systems run? Figure out who are the providers in clinic, what's their billing, how do they communicate their recommendations, how do they schedule, what's your protocols? Is this just like ours, where it's age and disease specific? Do you have anything that's more patient-centered? So we started off with just just phone interviews with the top 11 and then 12 altogether, and then kind of formed some themes and then a future survey after that. Overall, response rate wasn't too bad for the initial phone one and then the online survey. So of course, a surgeon, orthodontist, speech pathologist, they tend to be in the team. We added this component about copay and no copay. So we found that the billings, and that's one of the things that will come from this, the billing structure is all over the place. We want to know clinic duration. So in terms of this team clinic, the way it runs is, for hours, they come in at 8:30 and they keep going until the end of clinic. And I'll show that what sometimes it would last all the way till 5 o'clock. So you can only imagine how painful that is for the families. So clinic duration, some teams, 2/3 were in that 1 to 3 hour range, how long it takes for that families that they're staying there, while others, it's a lot longer in that 3 to 5 hour range. That's a long time. And there seems to be some correlation with follow-up with the longer clinics. We asked, like, how do you remind people to come back? Because you're not seeing them every week or anything. It's like every 1 to sometimes 3 years. And it's this, unfortunately, painful process of mail and phone, not much use of the EMR system. So when we ask the question, do you think you have a problem? And it seems like most of them seem to have some type of problem with follow-up. So overall, the number of providers, the type of providers that in the clinic, there's a wide variation. Billings all over the place. Communication is difficult. And it seems to be that everyone's still using the age and diagnosis specific protocols. So that's one. Then we're like, all right, how can we actually go the next step? And this was a commitment from the whole team. And the reason why we put it in this paper, I really want to highlight Kristen Pfeiffer. She is someone that it's such a crazy story. She was first a volunteer in our team clinic. And then I realized whenever she was the volunteer, our team ran the best. Then you start finding out, like, who are you exactly in this team clinic? And she was a patient with hemifacial microsomia. She went to law school, realized she didn't like law school. And then after that, I was like, why don't you be the research fellow and help us with this whole process? And then she just graduated from the med school this past year. The crazy journey. But she was key and instrumental in a lot of this kind of process improvement and really pushed it. And some of the biggest issues that we want to tackle was these long wait times, the clinic ending so late. These patients, they came in at 8:30. It's a attrition problem. And then access to the clinic, the clinic, we had a limited number of spots and it's booking out like multiple months. So the goal was to see how we can put everyone's concerns together. And we met every Friday morning before team clinic started at 7 a.m. for a good 6-month period. And it was a commitment. And I have to thank the team in Sydney, Australia. We searched high and wide to figure out who could actually help us. And they went through a similar process improvement system. So they some of this is very similar. So we went through the first few meetings every week, kind of what are the challenges? And fortunately, we came through with a lot. There was 73 different challenges. The next step was to brainstorm some of the solutions. And when it came to brainstorming, nothing was crazy. We asked everyone okay, if you were to figure out solutions, figure out from the perspectives of Disney, Gandhi, Google, and then just go ballistic with a James Bond option. And some of the solutions, anything can be written, and it doesn't matter how far-fetched it is. There was some family input as well. We wanted to know what the patients and their families thinking as well, and put all that together. So then there's solution implementation, and we kind of organized them. There was a few areas there was some waiting room issues, some scheduling problems, clinic experience, hiring, teamwork. That was key, because once we could identify some of the needs, we had 2 speech pathologists initially. Doing all this work allowed us to put all the information together to hire get a third speech pathologist to come to the team clinic. Cost and billing, I'll go into that a little bit more. And then of course the family communication. So it was nice when you put it all together, and when we saw green, that means we did it. And it could be just identifying resources wherever we can. Sometimes it was very solution just to get the clown dogs in, get the touch dogs in, just to help pass the time. So the family are just not having to ones bring their own iPad and try to keep everything calm. But then other things that came out of that was, especially when we talking to the families, they really hated it when everyone asked the same question over and over again. So as a group, we got together. What questions does everyone ask? Put it together on an intake form. And one of the first questions, probably no one can see it, is what issue and concerns actually bring you into the clinic today? What do you want to make sure you get out of the clinic? So our coordinator looks at that first and makes sure that's the first person that they see to make sure they get that answered. So it has helped tailor the day. We're not all repeating the same questions, and does kind of create some efficiency. Then we were able to get some funding to get some the process improvement team to come in. And I thought that was key, to have somebody from the outside to come in to kind of remove, because there are some difficult conversations that need to happen, because this is the way we do it. We know, why would we change anything? We're awesome. But sometimes having those difficult conversations, avoid the finger pointing, and they would identify areas that have barriers to some of the metrics that they identified. This is one of the things that they brought, ideas that they came to us, was just a simple dashboard, just to help the coordinators figure out where the patients are, who they need to see next. And only 2 people are allowed to touch this, the 2 coordinators. I have to make sure the residents do not touch this dashboard in any way, because then it ruins the whole system. This was great when we take advantage of the design team. The design team is always looking for projects, and it's free. So they helped us create this passport, especially for the younger patients. They get a sticker from each provider, figure out to make sure that they see who they need to see that day. This is another thing where I mentioned that education was a problem when they come to the team clinic. They didn't know that they needed to come back. So through the design team, we created these protocols, made a lot of edits to make sure it's easy for them to follow. And this is actually given to them on the back of the summary sheet when they leave the clinic that day, after how many hours that they've spent. And I think it's helped. Hopefully it's helped, and they know that they need to come back again for these reasons. So overall, when we looked at the evaluated outcomes, I'll just highlight, this is the main one. Yes, it's decreased the time, but it's increased the capacity. It used to have a 13 patient max for a morning. It's gone up to 18, and actually got everyone to be done by lunchtime. And 2 years ago, we actually started an afternoon clinic, and we had to do this to improve the access. Otherwise, that backlog was continuing. And especially if our attrition rates improve, we have to improve the access because that's more patients coming back. But the improvements are ongoing. Meetings happen every quarterly, and everyone, it's free to bring up any barriers, and everyone has a voice as to why we're doing certain things a certain way. So that's the challenges. Then the big one is the cost. And I wish I had more control over this, but I don't. But it is expensive. And we looked at it, and I tried for a long time to figure out how much are the families actually paying out of pocket to come to this team clinic. And one of the students somehow found a way to figure that out. And the charges are complicated. Every system is different. In ours, there's a hospital fee section. There is a professional fee because the physicians are part of the university. And then you got external fees as well when they see dentistry, orthodontics, and other things outside of the team clinic. So the aim was to just look back over a 6-month period and figure out what are the out-of-pocket costs from the hospital fees. We knew the professional fees, the co-pays are quite simple. Our billing structure, we had a level 4 and level 5. We did a 4 if they see less providers on that particular day. So the hope was, our assumption was that they were actually hopefully less out-of-pocket cost. This is what we found, that the range is quite high, and we only looked at commercial insurance. It's anywhere, it can be up to like $1,200 that they're paying out of pocket for that single visit, which average cost, not much difference between the two, $390 for a full, $310 for a mini. So not much, no very big differences between them. So because of this, we've gone back to our hospital and be like, can you give us some other categories that maybe a level 2, level 3 to try to decrease the cost? So at the end of the year, we'll look at this again. But I think it's ongoing, and sometimes you think you fixed it and then suddenly something changes and God knows why. And one of the families will call us and be like, oh my God, my bill is massive. And then we go back to bill and be like, why did it change? So I think it's ongoing looking at this. But then there was a survey component, and this one really stood out, that they like coming to the team. They like seeing everyone, but the cost is a burden, and it does impact, and really in terms of are they going to come back or not. So that's that one. I mentioned that, those protocols look great, but it's all very age and diagnosis specific. There's nothing about there in terms of how the patient's even doing. So we looked at a couple of our protocols, the one for isolated cleft lip, isolated cleft palate, just because they're easier. And just want to know, what are the interventions that are done when we ask them to keep coming back at all of these time periods. So looking at cleft lip first, they stop coming around age 5 on average. And the number of interventions are incredibly low. So to the point now, we don't have them come back to our team clinic anymore. They're just seen privately. And then when it comes time, if they do have a gap in the gum line, then we can always have them see the orthodontist separately for that. Opening up space for other patients that actually need to be in the team clinic. The next population is the isolated cleft palate. They stop coming around age 7. And even that, we found out the need for psychology dentistry is a lot lower, that we can probably use other screening tools for them, get them down to more at level 2, level 3 billing. And even the surgery follow-ups, there's not, the surgeons in the room, there's not many things that we follow where we looked at a healed incision for 12 years and try to bill every single year for it. So I think for us, that's one thing I'd love to remove. One thing I took away from this paper was we seem to have 2 groups. If they don't have much of an intervention, they seem to stop coming. If they have an intervention, they seem to come back. So that created a hypothesis. Maybe can we identify these patients so that we can concentrate on them, so to make sure that they keep coming back to the clinic. And at the same time, this paper came out of Boston, this idea, very simple, just optimal outcome, to them. And they just use the surgical optimal outcome, like no fistula, no VPD. And what does that mean? No fistula means no hole when you do a cleft palate repair. No veopharyngeal insufficiency, meaning that palate is working very nicely. And when it activates, it touches the back of the throat so they don't sound nasal. 2 of the most common reasons you have to do a second operation. So this was a paper that actually just got accepted. So thank you to Dr. Singh, the section editor, for accepting the paper. Would have been awkward if it was still in submission mode in your email. Yeah. But we want to take it a little bit further, because the hypothesis is that if someone has optimal outcome, they're going to stop coming, because there's only a few times that you tell them you're doing great, that they're going to be like, I don't want to pay $1,000 to come back. So we asked each of our team members, okay, tell us what you think is optimal. We also looked at neighborhood disadvantage to see if that's a factor in all of this as we're looking at it all. And there's 2 metrics that can be used. we found that if you are from a more disadvantaged, that you do seem to have more speech, language, and developmental concerns, but it did not impact follow-up in any way. So it shows that it's multifactorial. So the key finding, and we were hoping, boy, I really found something, but there was actually no correlation at all between optimal outcome and team clinic retention, like that original graph showed. So I think what it highlights to us that we probably need to figure out a way to just improve resource utilization and really focus on that population that really needs us, and start thinking about more patient-centered follow-up instead of, the disease age-based where everyone just comes back a year later. Advocacy. And I think, the main area that, and this comes back from the patients when we had those interviews, that the biggest one that came back was orthodontic coverage. And we know that it's complicated, it's state by state. We did this to just, and with Kristen being a lawyer at the same time, I was like, let me take advantage of your background. Can you explain all these different laws that the states have? Because, the problem is, that these denials causes delay, impedes access, such a waste. And you do have to develop almost different treatment protocols based on what access they have to orthodontic care. Our society decided that an orthodontist is so important that you have to have one to be a team. But clearly the coverage does not match that. And there's, out of the 50 states, only 18 actually have a mandate. So, and out of those, unfortunately, Arizona, Missouri is nice and dark and gray, so we don't have anything. But you can see that there's only 4 states that are actually favorable. And, Hawaii, it's favorable, but there's a limit. There's a cap on how much you can actually spend. So what can we do? And even in those states that mandate, it's not, the language is so variable. So there's this bill that's coming through, and it's the Smiles Act, and it's going to go through Congress again. If they can get their act together, I won't go politics. We'll skip politics. We'll skip politics. We're not going to do this, but it went through last time, but it needs to go through again. And the reason why this is great is it's got support. It's very broad support from all the organizations as well, and it does kind of extend to patients with congenital anomalies, and it includes dental coverage. There are no exclusions, and it really defers to the treating providers to make this happen. And we try to simplify it in this just to create awareness. And I think all of us all we can do is just contact our representatives to make sure that they support this. But I think there is a huge advocacy component that anybody's team, there's probably some barriers that need to be done. So looking at these 5, I feel like we have done a few things, and we probably have, taken these 7 steps into our, thinking when we were doing all the trying to become more patient-centered. But those are all things that we did just at the tertiary healthcare center. There's not much that we did in terms of the community. There's one that the speech pathologist did actually, where tried to do this collaborative care model with the local speech pathologists. And, the problems are, there's lack of training locally, and sometimes a disconnect between the local team and the team SLP. And we know how important speech is because it's required to be a Cleft center. And the solutions, and it came up very nicely. They made it billable so that everything is, everyone's happy, the higher ups. And there's continuing education locally, and it's helped with speech therapy and developing that continuity between the team and the local SLP. In terms of one of the other things, just the support that's needed to make this happen, and the research that needs to be done. All of this would not be possible without some support from the healthcare system. And then I highlighted here, this is our team. The providers do get support from the healthcare system to be able to actually see these patients. There's a few here in red that are 100% supported for us by the hospital. The coordinators, without them, there is no team. And of course, the fellow, database manager, the research coordinator, so we can actually continue to follow our outcomes. And this is why this is a great paper out of Denver that showed with the Colorado group that the Cleft care does generate substantial revenue. And I think this is why papers like this are valuable. And there has to be this partnership between the hospital and the Cleft team, because that's the only way that you can actually recruit and maintain, dedicated folks. I show this because you have to look at all of this. This is from the Institute of Medicine, and they try to operationalize the quality. And the goal is to see how we can do all of this, not just concentrate on 1 or 2, and to make it in a way to reduce waste as much as possible. some of the things that we're trying to tackle now, and this is like just happening now, that the last meeting was just past Friday, is how can we incorporate telemedicine? Anybody that's done coordinated care knows that patients cancel last minute. How can we at least give them a different option? And when we first introduce it, the team, they have to go through all the phases of like saying, oh no, we can't do it. But some of the myths are that the most vulnerable will not have access, reimbursement, they'll be different, and it's just not effective. And then this paper, our New England Journal, has really shown that none of these are really true. We asked our patients, if we did offer telemedicine, how more likely to come back? And almost half of them would like the option of having a telemedicine visit if it is available. So we went through the same process, same everything, gathering, brainstorming, and we're at that kind of still at the brain number 3, trying to go through solutions. And there are some issues like speech can't do telemedicine consultations in Missouri. There's a law for some reason that doesn't allow it. Illinois you can, but not in Missouri. So they, again, try to get that changed. So these are all the challenges. Oh my God, this is just slide 1. There's 3 slides. So it's a process, and you do have to take into everyone's account. I put this in when we talk about burden of care, focus more on the team care, but there is a surgical burden of care. So I've done good. I've done 30 minutes without talking about too much surgical stuff. But I think there is some surgical burden as well. And you can see Tom is also thinking about this as well. There are some huge peaks that occur. And this is a slide that I like to show to the families when they first come in. Even though we, in the US healthcare system, we have all the incentive in the world to keep operating every single time that we see them. I think it must be my national healthcare system that is still inbred in me, that I try to limit the number of procedures that we do. And there has to be this feedback loop. And the way I'm always thinking is like, if I see anything here that required a secondary procedure, could we have done something in that first year of life to make that better? And we try to have a system where just anyone should be able to just speak up and say something. So one of the key things, and again, this is where the orthodontist comes in again, is getting the patient set up. What's that component that sets the patient up in the right way so that you decrease future surgical burden? And there is this, what we call molding. How do we take a patient that has such a wide cleft and set that up so it looks like this when we're actually doing the operation? We offered 2 options. One is what we call nasoalveolar molding, a bit more involved, weekly appointments, higher cost, stent. And then, for our more long distance patients, we're offering this passive molding where it's just more appointments as needed and a lower cost. So of course, when the time came, when we had enough patients, we looked at them, and there's absolutely no difference in lip and nose outcome between the 2 3D measures and patient satisfaction. So now it's come to the point where the number of patients that actually do this more intense option is actually lower. And we look at the primary lip and nose repair. What control do I have to get this child up, set in a way that I decrease future surgical burden? And, there's lip repair, there's so many different techniques, but they all have the same goal, is basically just get height. And when we talk about lip height, I think the focus has been on the white part, the cutaneous lip. But this paper came out of Boston. The most common revision is actually in the vermilion and mucosal area. So then it came back to like, okay, what can we do to decrease this? And it's just, I hate technical papers, but this was one where it's just technical. How can we develop a system where it's like, all right, it's reproducible? And since then, the number of revisions have gone down and the symmetry is better. So again, decreasing that surgical burden and hopefully psychologically and socially just kind of decreasing some of that as well. When it comes to the primary lip repair, there's also the nasal component. And there's, the idea is, anybody who does fractures, there was a time in children where people used to say like, oh, don't worry about it, they'll grow and just be fine. And then Joe Gross, one of the famous pediatric plastic surgeons in Seattle, was kind of like, actually just reduce those fractures. And as the child grows, they'll do fine. And I think it's the same here, reduce those nasal cartilages. And I think there's many different ways to reduce it, but just reduce it whatever way you can. And as long as you reduce it, they seem to grow just fine. And it is a partnership with the orthodontist because the platform that it sits on needs to be set up appropriately as well. And that's the aim. Just see if you can get this so that you're not doing the early touch-up rhinoplasty. And we know that a lot of these patients will need a septal rhinoplasty when they get older, but at least you got them through without that burden. I wanted to put a special mention. There's a 10% of our population when we talk about lip and palate that are bilateral. Nobody likes them. Nobody likes them, but they're, and this is a famous quote from a past chief of my institution, that twice as difficult and half as good. And this is my patient number one, and it's this thing, what to do with this. And the reason why I picked this is just to highlight whenever you are seeing patients to listen to that inner red flag, that, these patients get set up as well with molding, get that thing back into position so it's in good alignment. But if it's in not good alignment, not be afraid to switch it. And, some of this is all newer, and, how long have I been doing this? It's just more recently. It's actually just get this back, get everything closed on the inside. I can do a better job with this now as opposed to this. But it's still up for debate. And I think that's the good thing, that you have to present all of this, talk about it at national conferences, speak to others. And I think that's the good thing about our society, is that we are very collaborative, and we do talk to each other. Everyone's always thinking, and everyone has a solution. And that's the only way that I can get an appropriate lip and nose repair and get appropriate height and columella length. And I think, everyone shows the outside, but this is probably what I'm more interested in. What does it look like on the inside? And I want to see all of this closed. I don't want to see this. Because this, unfortunately, the orthodontic burden, I can't do anything until they hit mixed dentition, which is around 8 to 10 years of age. They got to get expansion done by the orthodontist, and then I have to do a bigger operation to close it all. And the 8 to 10 range is like the worst time to operate on the child as well, so psychologically. When it comes to palate repair, how can we decrease surgical burden there? We kind of showed that the more you do with the muscle, so when you think about palate repair, it's not just bringing it together, there's actually a muscle component that you're supposed to bring together. And the more you do with that muscle, it seems to be that the less chance that you need that second operation for speech, probably the most common reason why you have to do a second operation. There are some newer ideas that are coming in. As plastic surgeons, we hate dead space. So whenever there's dead space, and we're always taught to fill it, and it's probably just been a few years ago. And I think that the team here is probably ahead of the curve in filling dead space with just fat from the buccal fat from the cheek. And likelihood, then I think they'll probably show in their data that as it's shown here, the palate's longer, and the chance of getting that fistula, one of the reasons why after the second operation, is lower. There's also this technique that's been popularized out of Michigan. Again, this is why you talk to everyone around the country, is the idea that sometimes you might need some extra tissue in there. There's a side of plastic surgery where, not all palates are the same. Some of them are shorter. And there's this tissue deficiency. When you do put the muscles back together, sometimes you have this big hole, and now you can use that cheek tissue to fill that hole. So these are all newer things that are happening. Do we know what outcome will this have? I think this is why you need that research team to be able to continue to follow these patients. So that first year is key. And you look at this, like the whole path that you take the patients through, everything is set up by these two procedures here. You get these two procedures right, you've hopefully decreased their surgical burden. One of the big ones that does come up when they are older is this alveolar bone graft, and we just had a journal club on it yesterday. Now, what is that? It's this gap in the maxilla that they have. And the idea is like to graft this. Why do we graft it when the moment that they're born? That's a bad idea that some people figured out a long time ago. It inhibits the growth of the face. So we tend to do it more around 8 to 10 years of age. Seems to be the timing for this tooth to come through so that bone comes with it. Of course, what the downside of doing this operation around 8 to 10 years of age, this is a great paper on UCLA. It's the worst time to operate on these patients and do all these orthodontic interventions. There are some long-term psychological impacts when you do too many interventions at the 8 to 10 years of age. So people are thinking like, what can we do? And that was the discussions yesterday. Should we be moving the bone grafts a little bit earlier? This is something that I saw out of NYU, and trying to make the bone graft outpatient as opposed to an overnight stay, and using something like this to harvest the bone graft helps decrease the pain. But there's this concept of boneless bone graft, and it's nothing new. It's been talked about since the 60s. This is, again, that patient number one. I hate to always go back to the end of one, but you do learn from, each patient. And in this particular patient, I did a setback, closed everything. 8 years later, when I saw them back, this side did not need a bone graft, bone formed. This side here, some bone form, but you can see why I failed. There's a little opening right here. It's just staring at me as to why that didn't work. But some bone formed, but everything's closed. That I just had to do a more simple procedure, make an incision, put some bone in, and it was outpatient. So since then, I've gone to the point of trying to close everything. And that's kind of highlighted here in this paper that's by Androl back in 2000s, where they did close everything, and it just shows these great pictures of bone forming. So we'll see. If I don't show any of this work in 10 years, that means it did work. But if I do, we'll take all the credit. So I think, highlighting to go through this whole process, it has to have this feedback loop. I mentioned that I kind of make sure that all the team members, whoever they are, feel free to speak up as to why are we doing the secondary, why are we doing more intervention on that patient? What could we have done in that initial first year of life to decrease that? And we all have to be comfortable with having these conversations. I think in terms of future directions, we're part of this with this group, and what I wish to include, and I haven't put it as much here, is include more patient-reported outcome measures. And this is one, we have what we call Cleft Q, and it's all these outcome patient-reported measures. And what I'd love to see is, how is my patient doing compared to all of the patients with the same pathology? Because when you think about it, you see these patients in the clinic, everyone's trying to go through as fast as possible. That patient and family only have a few minutes to actually express their concerns to you. And if you miss it, that's it. You're not going to see them back for another 1 to 3 years. But hopefully this will show that, like, okay, what do I need to focus on? And ultimately, it's a tool that I need to be able to figure out, like, okay, who actually needs to come back to the clinic and who do they need to see? The group out of Pennsylvania, CHOP, recently kind of looked at this. Is published ahead of print and on the website, and it did change their assessment and plan on some of their patients when they started using this, and about 16% of their patients. I put this in. This you may recognize the senior offer in this one, and there are barriers to try to get these standardized outcomes done, and it's not easy. Definitely, I think Europe's probably ahead of us a little bit when it comes to this, and they've already started this. I mentioned that at minimum, to be a Cleft team, you need a surgeon, a speech pathologist, and an orthodontist. And I don't know if Tom's thinking this, but I think at some point we probably should have some minimum outcome measures. I think that's where he's taking us. I can tell what he's thinking. Maybe not. But like, there has to be something to say, like, if you are a team, you have to at least put these minimum outcome measures out there. Because that's one of the 7 things that we were asked. There was supposed to be some research and dissemination. None of this work can be done alone. It's you can see the WashU network that's kind of helped to make that happen. But there's also now we're getting a lot more multi-institutional, and you have to do that to actually make this happen, to make some moves as well. Always have to thank the foundation. They're huge. Without their support, none of this would have happened. And huge thank you for the opportunity to speak as well. Actually got done a little bit early, so hopefully, I don't know if it'd be great to hear some feedback and see what other people are thinking as they're managing these medically complex patients. Thank you. Great. Hopefully, is that what you wanted?
Yeah, a great presentation.
Yeah.
One thing that I'm fortunate to be involved in 4 different multidisciplinary teams here at PCH. One thing that they all struggle with is this sort of pre-planning for the visit, which both includes the, like, who do they need to see, but then who do we need to pre-op with, and how far out to get that process. How do you guys handle those conversations around how far out do you plan for that child visit as a team, who owns it, and then how do you deal with the financial side of it?
Yeah, no, it is tricky. It's the coordinators are key. They're at least 4 weeks in advance. The schedule's already in our electronic health record, so it's in there. The team, the sheet is given out a week and a half in advance, so everyone knows the patient. So it's kind of on all of us to figure out, okay, and the ENT is great about, like, okay, these are the ones I need to see. Psychology does the same thing. Speech does the same thing. I wish I could do the same thing, but unfortunately, the rules at my hospital means I have to see all of them, regardless if they need me or not, to be able to allow the team to bill. But in terms of the insurance, that's the tricky one, and unfortunately, it's on the families to call to find out, and that's where then once they make that call, they find out like, actually, I don't want to see speech this time, or I don't want to see audiology because the out of pocket is high. When it's towards the end of the year, it seems to happen less, but until they hit that deductible, that they do decline some of the services. And we, I think in the past, we used to be like, no, you have to see everyone and almost force them, but we've kind of gone back like, no, let them choose who they want to see, at least have them come in. Yeah.
Yeah, thank you very much. It's a great presentation there. Thank you for keeping us honest as providers. I think it's really hard to look at our own outcomes and ask what can we do better. And I think the more conversations we have around that, the better we will become over at PR. Have you had the opportunity to apply these concepts to any other MDCs? Because I'm just thinking there are so many different MDCs in hospitals, and how can you apply this knowledge that you gain from your touch and facial practice and team to other MDCs in the hospitals?
Yeah, no, I think
You can repeat the question for those that don't know.
yeah, so the question is, how can this be applied to other multidisciplinary clinics? And a lot of our compensation happens with the administrators. And when we're building new hospital, buildings and everything, all the teams start off with like, oh, we want a whole multidisciplinary, clinic section and all this stuff. And then, the administrators are like, I'm hearing two different things. You're telling me it's actually really expensive and doesn't work that well. And, I was really want it. And I think it's just having everyone talk. So we've talked to the spine a bit for the team, some of the others as well. They don't seem to have the same challenges that we do for some reason. I don't know why. I don't know why Cleft tends to be a little bit different. I don't know if it's just the number of providers, the number of mixture between university employees and hospital-based systems. But they do, I think some of the billing stuff is still there. But I think just having that conversation with each of the teams is a good idea. I think there was a question in the back, yeah.
Those of us who run MDCs, I just want to make a comment question. We found, like you said, a lot of very last minute cancellations, which is frustrating when you are predicting on their 6 o'clock. We started, we backed up reauthorization process for 2 months. But our hospital will say it does help us with the process. One thing we noticed is that our patients are medicated, that's good. They're more likely to get approved. And yeah, that's not a part of our patients. But as you said, the other year.
Have you ever looked at as to the question came up of last minute cancellations, and have you looked at like why they cancel?
I think that one, I leave a lot of our patients in efficiency. I think there is.
Yeah. Yeah, and that's why I think I'd love to add telemedicine to ours. So if they are sick, they could, but boy, that billing thing is getting in the way. But we're trying. We're gonna try it. It's gonna happen.
That's your question. First, one of the things that we hope is a benefit of the thing is that they get to see all the providers in 1 day. Expensive. Once a year, we see surgeons, speech pathologists, and cardiologists all in 1 day. So we've got a question here on patients.
No, it is the current protocol for us is they tend to see everyone. Now we are starting to make those little adjustments based on what the providers think, what the patients say, where it's like, all right, let's decrease some of that to kind of shorten their day. And that's helped us increase that capacity. That's the problem. Like if we increase the retention, we have to see more patients and we have to figure out a way to how to do things. Then maybe skip them this year. Or at least have a tool to make sure that that the chance that they're going to say that you can have no recommendations.
What is the variation in time that patients spend with the provider? For example, like how many minutes are they doing the surgeon versus how many minutes are they allotted, like with the speech pathologist?
I deleted that slide to not be inflammatory. And I knew someone was going to ask, and yeah, it was always.
Always speech.
I mentioned whenever I speak at a national meeting and everything, it's fine when the surgeons ask a question. It's when a speech pathologist asks a question that you get most afraid, and it happened again today. But like no, it is, and it's a touchy one because I had it in there. And we looked at that, and the speech pathologist is the longest. It's the longest, and it's the that was the bottleneck for our team clinic because it was always a speech pathologist at the end. And so that was one of the impetus. All right, let's go from 2 to 3. And now the conversations are like, should the clinic time be a screen or should it be both, a more in-depth evaluation? That's open to interpret, and that's where we have to get input from everyone. But, the end goal is like, we have to be done at a certain time to start the next clinic. So I think it's,
I think that's one of the things we run into, right? It's like, as a speech pathologist, like, I need to do enough to make a proper charge, right? Like, for like billing code I have access to and balance that, but also keeping everybody outside. But I think there's also this balance, like, if they're at clinic, I want to do everything, but then don't have to increase their burden to recall them to like finish or for further testing. And so, do you guys ever like recall kids after the clinic to for like longer speech evaluation or more in-depth tags?
yeah, no, and we totally do. But I think it's probably the same thing. You get the same challenges for us where if they're a distance, you're going to try to do as much as you can because we don't have telemedicine as an option. We did during COVID period because, they allowed it then, but of course, as soon as that ended, we can't do it anymore. So I think if telemedicine is an option, then it does, if that would change it. That question, yeah.
Thank you very much for your talk. I've been parts of multidisciplinary clinics where they seem to function like this, where the patient goes from one provider to the next. And the difficulty is that then at what point does everybody get back together to discuss what their findings were and sort of arm wrestle for what happens next? The other is where all providers go in to see the patient simultaneously, and often that's not very easy to provider time. How do you balance it?
Yeah, so our model is the first one, and we know some teams that do the second one. It seems pretty daunting for a patient to walk in and see all these faces look at them. So we try to avoid that one. But you're right, that team, kind of meeting that happens after where you review all the patients. And we've gone through all the process where before it used to be after the clinic, everyone's tired. And for some reason, everyone's very chatty too as well. So they just keep drags on forever. So why is this taking so long? So then we tried it, we're like, oh, let's do it the week after, where we just like hit the high points, but now we've gone back to doing it right after clinic because it's become pretty consistent when we end. It was tough to do it when, the clinic's ending so late to get everyone to stay there. And of course, do some providers have to run to go to something else? Yes, but we can always get their input before they leave. But the goal is now just get it done straight after, and it's pretty much a bit of a small window, it should be no more than like 20-30 minutes to get through all the patients and kind of have that expectation that like limit the chatter during that period. Nicole?
How about like the staff and the team and having invited more staff and like work with the rest of the team?
Yeah, no, I think that's number one. The question is, how do you get buy-in from everyone? You mentioned both the actual team clinic and then the OR team as well, because there are different teams. I think the buy-in was what helped the most was seeing that attrition was seeing that like that if we stay with our current state, it's not gonna, we got to do something. So that was the first paper that really helped it. And just being open, I should be honest, but sometimes it does go a different direction, like the telemedicine one. When I brought up the first meeting, someone came in hot, just saying, there's no way we can do this. We just don't have time. Like, it's just not going to happen. And I was like, all right, this is going to be a slower process. And then you just slowly kind of keep edging away and, catch them on a different day. And then you try to say like, hey, this is really why we need to do it. Look at this data. Do you have any other options? And they're like, okay, you're right. Okay, let's see if we can really get this going. So I think just always listening as to why they're saying no, what's the barrier, and then just kind of bring them on. And then be academic as well, share the academic. You probably see us on all the papers. I included them all as authors because they were all involved in the process. To share academically really helps as well.
Just to follow up, I know you don't really want to get into questions, but I follow up on, I think when we look at the burden of care for families, and I know for our SLP team, we ask as surgeons, we ask a lot out of our SLP team to help guide us surgically, and their evaluations are longer. And so I guess looping back to patient satisfaction, if you look to see in the patient satisfaction and surveys that you've done, whether creating your expectations and giving them options. Well, you can come into a team day, but if you feel like you and your family can't tolerate having working visits, meaning a full speech evaluation or a full orthodontic evaluation, because our orthodontic team also to give the surgeons all the information we need, it's about an hour to an hour and a half of our orthodontic team, imaging, pictures, evaluation, to give them an option of screening visits and then come back individually versus like full team visits where they're having working, and then try to separate out those, like you were describing, mini clinic and full clinic, and whether that would decrease the attrition rate and improve patient satisfaction.
I'm going to add that to the intake form. Yeah, I'm going to just take that idea. But I think you're totally right. It is making adjustments, and all ideas are great in terms of. We do talk about the same thing. Should we do? Is this a screen? Because the psychology, speech, and the orthodontic ones tend to be the longer ones. Like how should can those be a screen? And right now, I think they're doing it without actually anything formal like that. Where it's like, all right, let me just see this one on the screen because they're just local. They're willing to come back, but we haven't formalized it yet. And I'll probably add that to my to-do for the next meeting. Oh yeah.
Tell us what your team meeting looks like who presents the patient, how long is spent on each patient, what your team meeting looks like?
Yeah, so actually, I try to present. So then, and I just try to talk as fast as I can through the whole thing. But yeah, that's how everyone tends to be there. Of course, ENT's already gone to the operating room, but they provided their recommendations. Sometimes the orthodontist might have to run as well. So not everyone's there, but we provided everything. Some are just on the phone. So we just cater. Like it's hard to ask all the providers to just be there and give up their afternoon time when they might have to run to do other things. So you do have to take into account the time for all the different providers as well. But if I'm not there, then one of the residents or the coordinator will do it.
You like the patient, review the plan, review the follow-up, next patient.
Yeah, and then someone's already inputting like when the next follow-up is to make sure we haven't missed anything. Of course, the easy ones, when it's like no recs, done, seconds. But there are some that need that discussion, and I'd rather spend that time on those complicated patients where it's like, all right, let's follow up on them. They need a bit more, especially with the new ones that have just come on, and they have a lot more involved. I think that's what we're trying to do is we do have limited time. So how do we focus on the ones that really need our care? Oh my God. Yes.
Administrative support. How does your hospital,
Yeah.
like, do they fund that or do you use portions from the foundation? So I know they're a big supporter.
Yeah.
How do you get the administrative support to run this type of successful program?
It's complicated. Yeah, it's a mixture of the two. So some because some of our service, the coordinators are the children's employees. They're not WashU employees. Once you start thinking about WashU support, then it goes through, the departments and eventually trickles down. So that's a different mechanism on itself. A lot of the research stuff, like the coordinator, the database manager, those are requests made through the foundation. So they kind of go after the donors. So I have to make that request every 2 years and show some productivity from like, thank you for giving us what you did for the last 2 years. Here's what output was. And And you have to make sure you message it. It has to be messaged in a way that like it ties into like how is it going to help the hospital as well. So you give us this, we do this, and it helps the hospital this way. So I think always when you're making the request, it's about what do they want to get out of it? They want to get those funds. Great. Thank you so much. Yeah.